Hi everyone. Hope y'all are doing really well through this midpoint of the week. Today, we're going to be talking about the social determinants of health. So you had some readings linked there on the Moodle page, and today we're going to be applying and summarizing some of the things we learned in the reading, but also then applying some additional knowledge here. So let's get into the social determinants of health. We're going to focus on this, and this is going to be a through line throughout the entire course as well. Same with social epidemiology in the following session. But the social determinants of health is critical and foundational to our understanding in medical sociology. So we want to introduce what the social determinants of health are into an in-depth standpoint. This session, that's what we're going to do, and we're going to look at the social determinants of health and their critical role in shaping health outcomes. So understanding these determinants is really essential for you all as sociology and medical sociology students to analyze broader health inequalities and how things are rooted deeply in societal structures and looking at, well, how can we make a difference there? What are the social determinants of health? So we're going to get into this further, but just to give a brief overview right now, the social determinants of health are the social, economic, and environmental conditions in which people are born, grow, live, work, age. These examples of social determinants of health include income, education, housing, neighborhood safety, access to healthcare. Access to social support networks. And these conditions directly influence health risks, access to resources, health outcomes, these sorts of areas. That's why they're the social determinants of health. And so another question, why should sociology students, why are we talking about this? Well, sociology provides tools to examine how social structures, policies, and inequalities affect health outcomes different than other disciplines do. That's why we're talking about it here. And the social determinants of health, they highlight the intersection of public policy and sociology, showing how health disparities arise from systemic inequalities rather than just purely individual choices. So understanding these things enables you as students and learners to critically analyze the role of power, the role of privilege, the role of policy in health. And there is this key connection here between sociology and public health. So whereas public health focuses on improving health outcomes at the population level, while sociology investigates the societal factors driving those outcomes. So there's this key through line here that we can better understanding these things will improve social policies. These sociological perspectives can improve social policies, improve public health outcomes, population health outcomes. So by grasping the social determinants of health through today, you all are going to better be able to understand the broader societal context of health inequalities and advocate for systemic changes to improve public health outcomes. And that's going to be a big goal, not just today, but the entire course. So let's get into it. Defining the social determinants of health. And refer back to Barkin chapter 5 here, where Barkin explains the social determinants and their effects on health. Barkin talks about socioeconomic status, education, neighborhood conditions, and access to healthcare as a few. And then also he describes how health behaviors are influenced by social norms, by peer networks, by access to resources. Let's define these a bit further. You see several key social determinants listed there. And I'm going to just briefly describe each of them, and you can refer back to the notes for descriptions as well. So, socioeconomic status. Income and wealth directly impact access to healthcare, access to nutrition, and stable living conditions. So, lower socioeconomic status is oftentimes associated with higher stress, poorer health outcomes. That's why it's a social determinant of health. Education. So, higher levels of education correlate statistically with better health literacy, access to information, healthier behaviors, ultimately leading to longer life expectancy. Neighborhood conditions. So safe and resource-rich neighborhoods support better health, while more disadvantaged areas often lack access to healthy food, green spaces, quality health care, and then access to healthcare itself, so as the third one here. Barriers to affordable and culturally competent care exacerbate health disparities, especially for marginalized populations. We've talked a little bit about what culturally competent healthcare can do and why it's so important in a couple of the readings. And think back to that. Why is it important to understand cultural differences and nuances and the type of the population that you are serving, that you are supporting as healthcare professionals in delivery and education, all these sorts of things? It's really, really critical. Social networks and support. So strong social connections improve mental and physical health outcomes by providing things like emotional support, practical assistance, and stress buffering effects. So conversely, though, social isolation, that feeling of isolation socially, that not having those support networks, that is often linked to poor health and higher mortality risks as well. Race, gender, and age here. So race, structural racism, which we'll talk about further here later in the day. Structural racism leads to disparities in healthcare access and outcomes, similar to those mentioned above. So historically, systemic practices like redlining, like medical racism, have excluded racial minorities from equitable care, while implicit bias is also so beyond just your maybe quote unquote typical sort of racial discrimination outcomes, also of the very overt individualized racism, that systemic racism, and then implicit and sometimes unconscious bias continues to affect treatment to this day as well. Gender norms and biases impact health behaviors and care experiences as well. So, for example, women and non-binary individuals in particular often face dismissal of symptoms. Men may avoid seeking care due to stigmas around vulnerability. So these social dynamics, the social construction of gender contributes to inequitable access, inequitable treatment, and just levels of different types of biases as well in the healthcare system that it's really important to be understanding of. And then aging populations also face unique challenges here, including chronic illnesses, mobility issues, and healthcare system strains. So ageism can also result in inadequate care or exclusion from health research itself as well. And then number two there, the influence of social norms and networks of these key determinants. So this is also important to identify as well. So just summarized, health behaviors are shaped by our peer networks, by cultural expectations and available resources. So for example, smoking rates, that's an example of something that varies across communities based on prevailing norms and the availability of cessation programs, because quitting smoking is also a costly endeavor in many cases. So that's an example of how our health behaviors are shaped by our networks and our social standing. Social support networks also provide emotional and material resources that mitigate stress and promote resilience in our communities. So think about historical events like urbanization, like redlining, or even current issues like food deserts or environmental pollution, disparities in COVID-19 vaccination rates, all of those things in a post-pandemic world. Think about how you connect those back to some of these key social determinants of health. So some everyday examples of how social determinants of health impact health. We've got eight examples here. So one, income and employment. So an example, a low-income worker may skip necessary medical appointments because they can't afford the copays or take time off with work without losing those key wages. Someone with stable employment and health insurance has a better access to preventative care and medications. And on the education front, a person with limited health literacy might struggle to understand a prescription label, leading to improper medication use. A college graduate is more likely to have a job with health benefits and the knowledge to navigate the healthcare system than someone without a college degree. That's just statistically speaking. Neighborhood conditions. So residents in food deserts have limited access to fresh fruits and fresh vegetables, increasing the risk of diet-related illnesses like diabetes. So if you wonder why maybe more disadvantaged communities have oftentimes higher risk of diabetes, that is a key reason why. And living in a neighborhood with high pollution levels can also exacerbate things like asthma or other respiratory conditions. Race and discrimination, number 4. Black and Indigenous women have, this is just one example, Black and Indigenous women have disproportionately higher maternal mortality rates often linked to systemic racism and bias in healthcare settings. Additionally, patients from racial minorities may experience longer wait times or fewer treatment options due to things like implicit bias, that unconscious bias. We'll explore that further. We have a specific section, a specific week upcoming on racial health disparities. We also have specific days dedicated to gender and age as well. Speaking of gender, number 5, gender and health. Women are more likely to experience the dismissal of their symptoms in medical settings, which often can delay diagnoses and treatment. Men may also, like it mentioned just in the previous slide, maybe be reluctant to seek care due to vulnerability, social norms, or they also avoid seeking mental health care due to societal expectations of things like masculinity and stigmas around that. Access to healthcare, number 6. So rural residents, folks who live in rural areas rather than the more urbanized areas, like say the Twin Cities or these bigger cities. Rural residents might have to travel longer distances for care. So this can often delay treatment for more serious and chronic conditions. Someone with health insurance can access regular screenings, while that uninsured folks may avoid care until conditions become more and more severe. 7, social networks and support. So someone with a strong social support system may recover faster from illness. And you might be wondering, why is that the case? Due to things like emotional encouragement and practical help and support on that front. A socially isolated individual might face greater challenges managing chronic conditions, leading to poorer health outcomes. And then finally, age. So age, older adults with more limited mobility may struggle to attend appointments or maintain independence, increasing their reliance on caregivers and that function in society. Younger people may delay care because they perceive themselves at less risk for health issues than maybe older populations, older individuals in society. I just ran through quite quickly a lot of examples, and please refer back to the notes that are on the Moodle page when thinking about these specific examples, because they're good ones, but there are so many different examples as well. I just wanted to help illustrate how the social determinants of health can shape our health outcomes in visible and subtle ways. And what this does is it underscores the importance of addressing systemic factors to improve public health. So they're really important to understand both the practical and theoretical side to the social determinants of health here. Fundamental causes of health inequality. So this really refer back to the Phelan Link article from 2010, where they're really emphasizing why addressing fundamental causes is critical for reducing health disparities. And just to give maybe a window or a summary into that reading, they're talking about how social conditions act as what they call, quote unquote, fundamental causes because they impact multiple health outcomes through a variety of mechanisms. So wealth, power, prestige give individuals access to resources that help to prevent or even treat health issues. And so the theory, the fundamental causes theory, argues that as new diseases and treatments arise, those with greater resources are better able to protect their health, to maintain. And what this does is it maintains health disparities. So again, the key summary of the reading there, and really that focus on wealth, power, and prestige, and how that impacts access to resources, which then exacerbates and maintains health disparities. So you see the 3 key points here. Number 1, systematic advantages or disadvantages. So higher income allows individuals to afford high quality healthcare, better housing, and healthier food, and educational attainment as well. Enhances health literacy, enabling informed decisions about treatments and prevention. And then additionally, occupation determines exposure to risk. So things like hazardous, maybe quote unquote blue collar jobs, and then even access to benefits like health insurance. While that's becoming it has been a trend over the past 50 years as a greater as just a more accepted benefit of access to health insurance, we are seeing a different landscape now with the gig economy, things like more contracted work. Think of Uber and Lyft as an example of companies that do not provide widely health insurance. If people like drivers necessarily. Now that is evolving and that is changing, but more and more that gig economy, that contracted work are places that are not providing health insurance, and there's a less cost on employers because of that, meaning that there's a greater desire to have those types of employees. So it's growing. Two, upstream versus downstream interventions. So the upstream approach focuses on structural and systemic factors like poverty, housing, and education to prevent health issues before they arise, whereas the downstream approach targets individual behaviors or symptoms. So things like smoking cessation programs, without addressing the social conditions that actually drive them. So it's less of a holistic and sustainable community addressing of these issues. So, for example, tackling air pollution would be an example of an upstream approach, which can reduce respiratory diseases, while treating asthma is the downstream approach that only addresses the symptom. Okay, upstream versus downstream approach. Three, why fundamental causes matter. So addressing only downstream issues, again, just where you're mostly addressing the symptoms, may temporarily reduce disparities, yes, but fundamental causes ensure that they will re-emerge with other things like new diseases or new treatment needs. And while tackling upstream determinants like income inequality and educational access is really the key piece to addressing and long-term health equity. So continue to think about, as we go through this course, about those through lines of upstream approaches versus downstream approaches, because we're really what medical sociology is teaching, and what we're going to learn is that those upstream approaches connected to the social determinants of health produce greater sustainability in health outcomes at the community level. So fundamental causes of health inequalities continued. So again, I just want to reemphasize that concept of fundamental causes of health inequalities through that Phelan article represents a major theoretical framework within medical sociology. The approach here of the fundamental causes shifts the focus from those individual health behaviors and medical interventions to broader thinking sociologically, broader social and structural factors that perpetuate health disparities over time. So regardless of changes in disease patterns or medical advancements, by ignoring fundamental causes here, we are ignoring the root causes of issues, and issues will continue to persist and evolve in different ways. So core principles here of fundamental cause theory. Number one is access to resources. So this theory posits that individuals and groups with greater access to critical resources such as money, knowledge, power, social connections, and access to high quality healthcare, they're better positioned to protect their health and mitigate the effects of illness. So these resources facilitate advantages in navigating health systems, securing better care, and adhering to health promoting practices. Number two, persistent inequality. So even as new health threats emerge and medical technologies are continuing to advance, health disparities continue to persist because those with greater social advantages can continuously leverage their resources to maintain those better health outcomes. For example, new treatments or preventative measures such as early cancer screenings and vaccines, those sorts of things, are often adopted first by individuals in higher socioeconomic positions. And this just further reinforces those existing and long-term health gaps. Three, mechanisms of inequality. So fundamental causes are flexible, okay? They shape health outcomes through various mechanisms over time. This adaptability explains why, despite even significant medical and technological progress, inequalities don't just disappear. For instance, even when specific risk factors like smoking decline, broader social inequalities manifest through new channels like diet, like stress management, like access to clean environments. These things are more fundamental. That's why it's the fundamental cause theory. Four, policy implications. So addressing health inequalities effectively requires interventions that target upstream social determinants. Remember, upstream that comes back more and more, such as things like poverty reduction, educational improvements, policy measures to reduce systemic discrimination. So without in policy though, without addressing these underlying structures, without upstream approaches, efforts to promote health at the individual level are often insufficient to close that health gap. So those are the four core principles of fundamental cause theory. And think about that more and more as we talk. And this is going to be something that we'll come back to, and likely that maybe in certain assignments that you may come back to throughout the course. Fundamental causes of health inequity. So just some examples here. So some more sociological insights and examples. So with socioeconomic status. So again, we've talked a little bit about this, but just to reinforce, individuals from lower socioeconomic status backgrounds often face cumulative disadvantages, such as limited access to healthcare, nutritious food, safe living conditions. Sociological research highlights how this leads to a cycle. It's not just a one and done, it's a cycle where low socioeconomic status individuals and low socioeconomic status not only contributes to poor health outcomes, but also reinforces economic and social barriers. That's really important to understand that upstream effect and that cycle effect there. Racism and discrimination as another example. So in the TED Talk that is in the assignment to watch for this week, David Williams is the person who does that TED Talk. David talks about systemic racism and how that functions as a fundamental cause by influencing a wide range of health outcomes. So he talks about things like chronic exposure to discrimination, inducing stress that adversely affects both physical and mental health outcomes. And then he talks about structural barriers such as discriminatory housing policies, redlining, unequal educational opportunities, further compounding all of these things. So again, that's cycle effect here, because that's what I think a really good point to emphasize here, that those upstream effects break into that cycle of poor health outcomes, whereas the downstream effects tries to just mitigate the essentially overall impacts, the symptoms of the effects, not the root causes. So again, refer back to that TED Talk. And then finally, number 3, education as a determinant, social determinant of health. So higher educational attainment statistically correlates with better health outcomes. And education not only provides knowledge about healthy practices, but also enhances access to job opportunities, to access to social networks, and access to better living environments. And this reflects how disparities in educational systems contribute to long-term health inequalities as well. Okay, so were some examples of those fundamental causes, and now we're going to talk. Let's talk a little bit about policy and contextualizing policy and why that's important. So, from a sociological perspective, health interventions have to move beyond individual-focused solutions. Again, those downstream effects approaches like awareness campaigns or behavior change programs. While such initiatives can yield and do yield benefits, they often overlook those structural roots of health disparities. Sociologists argue that effective policies have to incorporate those 3 things you see above there. So, number 1, comprehensive social safety nets, these that ensure basic living standards. 2, community-based initiatives that empower marginalized populations through participatory approaches. So if I'm going to implement a new public health related initiative, I need to make sure that the populations that I'm trying to support, especially those marginalized populations, are a part of the actual designing of that approach. And then 3, equity-focused legislation to dismantle systemic barriers and ensure equal access to resources, making sure that everyone equitably has access to the type of resources that we're trying to provide that are going to improve health outcomes. Case studies in practice. So just a couple of examples, and I think it's unique to highlight these examples. So public health campaigns versus structural campaigns. Let's talk about this. So for example, I think the anti-smoking campaigns are a good example. So while anti-smoking campaigns have been successful widely, higher tobacco taxes disproportionately impact lower income smokers. Think about that the higher tobacco taxes, which have been a part of the anti-smoking campaigns, impact lower income smokers more, who may lack the resources to stop smoking. Because a lot of people use additional resources. It's hard to quit cold turkey, right? So it more negatively, disproportionately impacts those low-income smokers. And this outcome shows the need for supplementary policies, such as accessible cessation programs and educational research tailored to those disadvantaged communities. Again, that participatory function like above. And then the COVID-19 and health disparities there, this example. So the COVID-19 pandemic really illustrated how fundamental causes operate. So think back now, because now we're in a quote unquote post-COVID world. Think back to your COVID experience, what you learned from that. Those with greater socioeconomic and social resources were more likely to work from home, to have access to vaccines, and receive timely health care. And this starkly contrasted with essential workers and economically disadvantaged groups who faced higher exposure and had more limited healthcare access. Again, showing how those fundamental causes and these social determinants impacts something like a pandemic and our experiences around a pandemic, not just maybe your typical chronic diseases, but things that spur up that we are unprepared for widely still disproportionately impact those certain groups. So in summary here, the fundamental cause theory underscores the persistence of health inequalities due to the deep entrenchment of social and economic disparities. And what the theory advocates for is a shift in public health and policy focus towards upstream interventions that reduce structural inequalities and redistribute resources more equitably. Addressing these fundamental causes involves tackling social hierarchies, tackling power dynamics, and creating more level playing fields for health equity as well. And then further, by acknowledging the sociological underpinnings, again, this being a sociology course, the sociological underpinnings of health disparities, policymakers, public health professionals, maybe some of you who are going to be doing this work in the future, can design interventions that promote more sustained long-term improvement in population health. Again, those upstream effects, not just the downstream approaches. The systemic racism in health. So this comes from the David Williams TED Talk, and in how that illustrates how systemic racism actually operates as a social determinant of health. So go to that link and watch that. There's actually I'll pull it up here so you can kind of see what it looks like. It actually didn't pull up for me. I'll try it again. There we go. There you go. So here's the TED Talk link. Make sure you watch this. It's about 17 minutes long. Make sure you watch it and then reflect on how these things, what we just talked about, how they are identified by David Williams. So, and just as a summary too, he talks about the things we've kind of already mentioned, but how racism is both structural and interpersonal. How these things, he talks about chronic stress, which has psychological effects leading to poorer health outcomes for more marginalized groups. And he talks about different examples, including higher rates of hypertension and preterm births among African Americans in the United States, and then linking that to chronic exposure to discrimination and inequality. So take a look and make sure that you do read that as a part of the assignments for the week. Okay, so systemic racism and health continued here. So when we talk about systemic racism, that's kind of a buzzword now, right? It's kind of a buzzword in society. So I want to explain what is systemic racism. So systemic racism refers to the institutionalized practices, policies, and norms embedded in social systems that create and maintain racial inequality. So it's different from individualized overt racism, such as slurs and direct discriminatory practices that folks might experience on an individual level. Unlike that individual level racism, systemic racism is embedded in the fabric of major social and societal institutions, things like education, housing, the labor market, and the healthcare system. So these embedded structures perpetuate these inequalities that disadvantage racial and ethnic minorities. That's what we mean by systemic racism. That might be outdated practices or things that we haven't identified or issues that are not being addressed from a systemic aspect. And in the realm of health, systemic racism acts as a significant social determinant that shapes health disparities through both direct and indirect pathways. And sociological research highlights that understanding and addressing these mechanisms is really essential for promoting health equity. So let's talk about these mechanisms through which systemic racism affects health. There are 5 key areas here that I've included. So Economic inequality and poverty. So some historical context here. So policies such as redlining and discriminatory mortgage practices limited where Black and other minority families could actually live in society, in United States society, leading to long-term economic disadvantages. Generational wealth accumulation was hindered, leaving many minority communities economically disadvantaged. And we know that income and socioeconomic status is a direct social determinant of health as well. And those health implications, right? So lower economic status restricts access to healthcare, nutritious food, safe housing, quality education, all crucial factors for maintaining long-term health outcomes. And then economic stress is linked also to higher rates of chronic conditions like hypertension, like diabetes. Number two, residential segregation. So residential segregation is a direct result of historical and policy-driven discrimination, and this continues to affect minority health outcomes to this day. Segregated neighborhoods often have fewer healthcare facilities, reduced access to healthy food options, and even greater exposure to pollutants. Public health consequences here. So these environments lead to higher rates of asthma, chronic illnesses, lead poisoning, other environmental health issues. And this and limited access to recreational areas also reduces opportunities for physical activity, contributing to higher rates of obesity and related illnesses. Number three, access to healthcare. Systemic racism influences the structure of the healthcare system itself, and this affects access, quality, and outcomes. And minorities often live in areas with underfunded medical facilities and are much more likely to be uninsured. Implicit bias is also prevalent here. So within healthcare settings, implicit racial biases can lead to disparities in diagnoses, disparities in treatment and pain management. For example, studies have actually shown that Black patients are less likely to receive pain medication compared to their white counterparts, even when presenting with the same conditions. Maternity mortality rates. So Black women in the United States experience maternity mortality rates nearly 3 times higher than those of white women. This is a disparity driven by these systemic barriers and bias in maternal care. Number 4, chronic stress and health outcomes. So the role, so chronic exposure to stressors associated with systemic racism, such as workplace discrimination, microaggressions, social exclusion, this can lead to what is known as the allostatic load, or the wear and tear on the body over time. So this cumulative stress has been linked to increased risk for cardiovascular disease, mental health needs and disorders, and other chronic illnesses. And in that, again, that David Williams TED Talks, it's a really good one, and that's why I keep referring back to it. David talks about how racism acts as a toxic stressor, resulting in poor health outcomes among minorities, including the physiological response to chronic discrimination, and how that can lead to premature aging and heightened susceptibility to various diseases. Finally, number 5, health behaviors and access to healthy choices. Systemic racism limits opportunities for individuals to make health promoting choices. So neighborhoods shaped by discriminatory zoning laws may lack grocery stores with fresh produce, while fast food options really are widely available, making healthy eating more and more difficult because they are cheaper, oftentimes more readily available. And then cultural and social factors here are important too. So health behaviors cannot be separated from the social contexts that shape them, right? The normalization of unhealthy food environments and reduced access to physical activity due to safety concerns further contribute to health disparities. And those, you can't separate the two. So these are 5 examples. Again, refer to the notes and look back on each of these descriptions here. But this is an example of how systemic racism actually does directly impact health outcomes. Connecting theory to practice. So really all I want you to think about here is linking the more theoretical concepts of the social determinants of health and the fundamental cause approach to the practical public health policy. So emphasize the importance of systemic interventions to reduce health disparities effectively, because you all are likely going to be professionals that maybe are on the front edge of some of this work, and it's going to be really important to have this perspective. So just some couple of key points here is that policy interventions to mitigate health disparities. There's some examples I'd encourage you to think about, like education related. So policies that increase access to quality education. These could be things like funding for public schools, affordable college programs. These things can improve health literacy and employment opportunities and long-term socioeconomic stability. Housing related initiatives as well, like affordable housing programs, rent control, urban renewal projects. These things can improve living conditions and reduce exposure to environmental hazards. And then another just example I wanted to mention too, that economic support. So policies such as raising the minimum wage, universal basic income, or tax credits for low-income families can directly alleviate poverty as well. And there are so many different challenges to implementing things like this, but these are just examples of ways to think about it, just to enable better access to healthcare, nutritious food, other essentials here as we think about the social determinants of health. And then systemic versus individual interventions, right? So holistic systemic interventions address the root causes of health disparities like poverty and structural racism, rather than just the individual behaviors like diet and exercise. While both have their place, we want to think about those upstream approaches. Another example here would be investing in public transportation and how that ensures widespread access to healthcare and job opportunities, unlike focusing solely on personal transportation solutions. Just another example of how we want to be thinking about these things from a sociological and medical sociological perspective. Finally, just you see a quick summary here of these key points that I want you to be thinking about. That social determinants of health are foundational to understanding disparities in health outcomes, and that fundamental causes like socioeconomic status and systemic racism and systemic sexism shape access to resources that promote health. And then finally, addressing the social determinants of health requires policies that go beyond healthcare to encompass broader social changes. So be thinking about these things, as these are going to be through lines through the entire course as we talk about the social determinants of health. It's really, really important. Now, that's all I've got for today. So if you have any questions or want to connect one-on-one, as always, please reach out to me to do so. Thanks again for tuning in today.